Good morning, all. So we are starting with UDDHAV Memorial Symposium, Demystifying Vertigo. Uh, I welcome moderator for the session, Dr. Ramessh Rohiwal. Sir, he's already there, and the session is handed over to sir. Okay, we have 7 talks by the experts. The first being Dr. Prashant Kewle, talking on vestibular migraine, clues in history. The second one is vestibular migraine and pharmacotherapy by none other than Dr. Srinivas Dorsala. The third is Meniere's disease, escalating ladder of management by Dr. Ramessh Rohiwal. Fourth is recurrent BPPV, causes and how to reduce recurrences by Dr. Dushyant Khedilkar. Fifth is how to rule out stroke clinically and confidently in acute vertigo by Dr. Sonali Pandit. Sixth is orthostatic hypotension, golden rules for recognizing and management by Dr. Pushkar Kasat. Seventh, must know nystagmus patterns in vertigo by Dr. Swanand Golap. I hand over to Dr. Ramessh Rohiwal.
Respected Chairman, sir, at the very outset, I want to thank Dr. Prasad, Dr. Girish, the Solapur AY for providing this opportunity to us to present something about the topic which you just recently, just now we had a lecture by Dr. Srinivas Dorasala. I request moderators to start announcing the sequence. Yeah. I'm not having with me.
The first speaker is Dr. Prashant Kewle for vestibular migraine, clues in history. Dr. Prashant Kewle.
I request Dr. Prashant to go ahead with his presentation.
Thank you. Good morning, all. So my today's topic is vestibular migraine, what clues you will take from the history. When the patient comes to your clinic, you want to see that this patient is having peripheral vertigo, central vertigo, or it is systemic vertigo like hypotension, diabetic, whatever. But when you cannot localize, this is unlocalized, and there is what is migraine. Migraine, there are many types of migraine. To understand what features it will give, let us understand the pathophysiology. So there is a hypersensitivity of the central neurons, and there is a spread of current. We know when it is in the thalamus, which is for the perception of pain, and therefore in migraine we have severe pain. If the cortical spread goes along the trigeminal nerve, we can have pain along the face, along the maxilla, along the mandible, along the forehead. It can be pain behind the eye, that is retroorbital pain, severe. If the spread goes along the parietal lobe or the frontal lobe, patient can have internal vertigo. What do you mean by that? Patient feels everything is dizzy and he feels imbalance. If the cortical spread goes along the limbic system, there may be some features which are like abnormal behavior also. And they all will be lasting till the spasm lasts. If the spread goes toward the brainstem, it is basilar migraine. And brainstem, we all know, are having third, fourth, sixth nuclei which are responsible for eye movement. Also, we have nuclei for the saccadics in the brainstem. So the brainstem, if it is a basilar migraine, will show all the auras. There will be visual disturbances. There will be flashes of light. Patient may see some objects are bigger than the normal size. All these features are because of involvement of brainstem and the nuclei of the eyes lying there. If there is a spread to the meningeal vessels, there will be pulsatile headache. So these are features. And now what happened in vestibular migraine? There is a spasm of the vestibular vessels because of spasm of ICA. If it is involving the vestibular blood supply, it will give vestibular dysfunction till the time the spasm lasts. And therefore, these patients will have all symptoms of vestibule. That means the canal symptoms. Patient sees everything else is rotating. When there is a stimulation of saccule, the patient feel that they are falling down. There is a projectile fall sometimes because of stimulation of utricle. So all these features, what you see in all your vertigo patients, will be seen in migraine patient possibility. And the main problem is these will last till the spasm lasts. And the spasm can last for 60 hours. And therefore, the features and the definition goes like this. There are at least 5 episodes of vestibular symptoms. They may be moderate to severe and lasting from 5 minutes to 72 hours. The bigger window is there. There may be history of headache currently, or there may be in the past, and the headache is very severe, pulsatile, and with the throbbing headache, it is aggravated by physical activities. It will be severe pain, and there will be photophobia, phonophobia, and auras. Not better accounted by any other vertigo diagnosis and responding to migraine therapy. So we have seen what are the symptoms. There could be internal vertigo, feeling imbalance, dizziness. There could be external vertigo, actually seeing the rotational outside. All these are aggravated by head motion, or head motion may induce this vertigo. Visual induced vertigo, when patient try to screen his mobile or the laptop, or when he is seeing the moving objects like a train moving in front of him, when that time he may get vertigo and dizzy episodes. Positional vertigo can be there, but these are atypical positional vertigos. And yes, our labyrinth is responsible for spatial orientation, and patients do get disturbed spatial orientation in the episode of vestibular migraine. The headache will be very severe, throbbing headache, always, or maybe with the auras, nausea, vomiting will be there. The patient want to sleep in a closed room without any light and without any sound. That is classical, they will describe. Some patient may also say that there are flashes of light when the episode is going on. We have to ask history in detail. We have to ask history, because sometimes patient doesn't give history of headache and only comes with the vestibular symptoms. You ask them, they may have childhood migraine, headache. They may have abdominal migraine in childhood. They may have BPVC, that is dizziness and fall, in childhood. We have to ask history of family because it runs in a family. And sometimes when you are asking the patient, there may be history of vestibular symptoms, and in his sibling, there may be the history of headache. So that says it is a family history. Many triggers are there for the irritations. So skip meal, lack of sleep, excessive traveling. Some people are having, after a hectic day, they do have episodes of this migraine. Optokinetic motion we have seen, when they see a busy or checks pattern, when they're seeing stripe pattern, that may induce this kind of vertigo. Strong smell of coffee, tea, strong light because of involvement of limbic system. So all these features are triggers, they will induce this vertigo. So now let us see. And we have to 100% make out that neuronitis is not there. This is not positional vertigo. This is not Meniere's. So this is by your clinical examination and test like MRI brain, VNG, audiometry, and nystagmus during the episode will lead you to diagnosis of migraine. So let us see a small case. Our dizziness, how it feels like.
At times I feel like I'm feeling blank. Sometimes I get like different colors. Sometimes it's completely blank. I lose vision for a temporary period of time like that. And it's very, very severe. When it is very severe, then I feel like everything is moving around me.
So this one lasts for how much time?
It lasts for around 1 hour, until and unless I don't sleep for some time, or until and unless I don't just go out in fresh weather. Otherwise, if I stay in that place with that headache, and at times I don't feel like listening to music also. So it's that severe.
But it will be always with headache?
It is associated with headache. It starts with headache first, right from my spinal cord at times, but mostly starts from forebrain. So here it spreads across, and it is like near my ear, and then it comes down to my eyes get swollen, and then after I start losing my vision temporarily for an hour or so.
So the headache will become very severe first, or it will start with blur and then it will become, how's that headache?
No, first it becomes severe, and gradually then the vision, and then headache, and then I feel pain near my ears and the entire jaw, and I don't feel like eating because there is a pain. I cannot open my mouth at times. So that is how. Does
your headache start with sunlight or strong light? Is there any association you feel?
Strong light, yes, not sunlight, but strong light. If there are like high frequency lights or anything like related to different colors, very bright, and if it is associated with high music sound and a mixture of sound, then it starts. Like dholak kawas during festivities, like that Nashik dhol, then it starts for me and for my mother, similarly.
It's there in my mother also, it's a family history. So you have to spend time in the history to get the clues for the migraine. Your history and your examination will give you 80 to 90% of diagnosis. 10% is proved when you are seeing the negative reports or the normal reports of MRI or VNG. So this is how the migraine goes. Thank you all.
Thank you, Dr. Prashant, for a very crisp and informative talk. We'll keep question answer session at the end.